We want to welcome our listeners to Unmute Your Probe podcast from the AAEM ultrasound section. This podcast is from the ultrasound section of the American Academy of Emergency Medicine and will cover EMS and pre-hospital POCUS in collaboration with the Emergency Medical Services section of the AAEM. CME is available for AAEM ultrasound section members through the AAEM website. I'm the host for this episode. I'm Dr. Stephanie Marrero Borrero. I'm an assistant professor, affiliate faculty in the Department of Emergency Medicine at Ponce Health Science University in Puerto Rico, and EMS coordinator, as well as ultrasound division faculty of the Emergency Medicine residency program at San Lucas Hospital in Ponce, Puerto Rico. I did my EMS fellowship at UT Health San Antonio, Texas, where I then decided to stay for another year and thankfully had the opportunity to complete the clinical ultrasound fellowship as well. I'm also the current secretary for the Emergency Medical Services section of the AAEM. And today we will focus on two important guests. We have Dr. Katherine Raczek and Dr. Eva Tovar Hirashima, who will discuss POCUS on the go, EMS, and pre-hospital POCUS. So, Dr. Raczek, tell us a little bit about yourself. Where are you working at? What are you doing? And where did you train?
Hi, yes, thank you so much for having me. This is very exciting. I'm so excited for this collaboration. So I'm currently the chair of the EMS section for AAEM. And I'm an associate professor of emergency medicine at UT Health San Antonio in Texas. I'm the EMS medical director for Bexar County ESD number 2 Fire Department and one of the associate EMS medical directors for the San Antonio Fire Department here in San Antonio, Texas. So thank you again for having me.
So nice. Thanks for being here. Welcome also, Dr. Tovar. Please introduce yourself to our audience and share a little bit of your background.
Sure, yeah. Thank you so much for the invitation. So I'm Dr. Eva Tovar Hirashima. I currently work at Riverside in Southern California. I'm an assistant professor of the University of California, Riverside. I'm currently the ultrasound division director and the ultrasound fellowship director. And in addition to that, since 2019, I've been the medical director at Cruz Roja Mexicana in Tijuana. So I've got the privilege of working on both sides of the border in different capacities. And I'm very excited to be here to discuss a little bit about POCUS.
Nice. Thank you both for being here. We also want to welcome all the EMS professionals, including paramedics, as well as EMTs, emergency medicine physicians, students, residents, and trainees in emergency medicine, fellows in training of both clinical ultrasound, as well as EMS, ultrasound enthusiasts, and educators, as well as policymakers in the pre-hospital care. So let's start talking about why POCUS in the pre-hospital medicine. Dr. Tovar, as an ultrasound fellowship trained, talk to me about the importance of not limiting the POCUS to the hospital, but also implementing it in the field for the care of the patients.
Yeah, for sure. I'm going to start with something in Spanish. One thing that we say is, si las urgencias empiezan en la calle, hay que llevar ultrasonido a la calle. And basically what that says is, like if emergencies actually start in the field, we should actually bring point of care ultrasound to the field. So pre-hospital POCUS can be a game changer because it does bring advanced diagnostic capabilities to the field, and it provides real-time actionable information that can influence both the patient management as well as patient outcomes. I think it's important just to give you a few examples. So kind of breaking it down into these. The first thing that I would say is that point of care ultrasound enhances diagnostic accuracy. And we can see this in our trauma patients. So whenever we use FAST, which is focused assessment of sonography for trauma, and we identify the presence of non-compressible hemorrhage in either the abdomen or the chest cavity, our EMS colleagues can then prioritize transportation of non-compressible hemorrhage to a trauma center. Second, point of care ultrasound can also help with appropriate treatment. And I think that a good example of this is in our patients who present with respiratory distress. Imagine being in the streets or on the streets. Stethoscope usually doesn't help much there. And if you have a patient who has a respiratory distress and also has a history of CHF plus minus COPD, using point of care ultrasound or using thoracic POCUS, which is incredibly easy, something that can be done within a minute or so. Our EMS providers can make that distinction between B lines versus an A line pattern. And based on this, they can decide, okay, let's just go ahead and do CPAP and nitro versus let's go ahead and do albuterol. So I think that's incredibly powerful. And third, I think that point of care ultrasound can also help with better resource allocation. And I can give an example of a recent EMS colleague who's actually a general practitioner too. And so she was called in to respond to a patient who was hypotensive. This patient had a prior history of a AAA, was bedbound. And as soon as she arrived, she noticed that the patient was hypotensive, popped out the handheld ultrasound that we have in our ambulances and realized that the patient had a AAA with signs of contained rupture. And so instead of transporting this patient to the ED, where you know, as just like in the US and Mexico, our public hospitals are also understaffed and they can get all the help they can. Once she identified this AAA that was contained and discussed this both with the patient and the family, discussed the prognosis, they decided that it was best for her not to be sent to the emergency department. So I think that point of care ultrasound can help with resource allocation, which is especially important in resource limited settings.
Yeah, I agree. It's not just about having another tool, right? It's about like reshaping the standard of care, basically. Dr. Raczek, can you highlight how POCUS can overcome some of the challenges that you've seen?
Absolutely. I can't agree more. You know, as an EM physician, obviously we are very, lucky to have such incredible tools, as you mentioned, in the ED setting, a lot of staff, nursing colleagues, techs, et cetera. And in the pre-hospital setting, we're trying to really change the culture and the standard of care, as you mentioned, Dr. Marrero, in terms of our EMS clinicians and really turning them into clinicians, not just ambulance drivers, right? So those days are over. The days of you call, we haul, that's over. Of course, there are some situations in which obviously the patient will need definitive care. And of course, the transport will still take place. But, as an EMS physician, in addition to an EM physician, I want to empower my EMS personnel to have the skills to really start taking care of the patient immediately upon assessment of the patient. So just like Dr. Tovar mentioned, with, the care does not begin in the hospital. It's really a continuum of care. So, the care begins at the first contact of the patient. And the more we can do for the patient, even in a short transport time, the more refined our care can be. It's more finessed, it's more elegant. We're bringing our EMS colleagues to a higher level, of pre-hospital care that can then continue through the ED and beyond in the patient's emergency medicine journey, if you will. So I absolutely agree with those three examples. And I can think of several more that I'm sure we'll discuss. But I think, some of the challenges are to get past that concept of this is not something paramedics can do, or it's too complicated, or it's what's the point, or maybe it's a waste of time, delay in transport, et cetera, et cetera. And we can address some of those challenges. But I think the first step to overcoming some of that is really emphasizing that cultural change, as we've discussed, of the care should start immediately. And just like we treat pain, just like now we have an emphasis on pre-hospital sepsis treatment, improved trauma care, pediatric care, ultrasound is another skill and tool that can be added to that arsenal to really help the patient as quickly and as efficiently and thoroughly as possible.
I definitely agree, right? By doing that cultural change, like you said, and that mind shift, we can also help build some type of confidence in our paramedics, and that way they can manage anything that it's possible in their hands, even complex medical or trauma cases. So speaking of managing, what clinical applications of the POCUS in the field do you believe are most important I love that Dr. Tovar started with some examples, but I believe, right, that probably you've been thinking of specific type of scenarios where it plays an important role. Dr. Tovar, in your opinion, what role does POCUS prove to be most beneficial?
So I think that depends on your EMS it depends on the population that you're treating. So the way how we decided how to use point of care ultrasound and incorporated it to our different protocols was looking for STAR statistics, and just looking at the patient population that we treat. And so in our system, we see a lot of patients who have, well, trauma is a big one, of course, and we see a lot of penetrating as well as blunt trauma. And these patients represent 40% of the patients that we see. And in addition, they're the critical patients that we take care of. In addition to that, we also saw that a lot of our patients or a lot of our ambulances were responding to obstetric emergencies, not only in the first trimester, of course, but also in the second and third trimester. And then with regards to the medical conditions, we saw a lot of both cardiac and dyspnea or shortness of breath as complaints that are seen in pre-hospital. So based on these, we kind of designed the different applications that we were going to use. We're going to talk probably more about this with more detail in the next couple of minutes, but I would basically say that in our system, eFast is definitely an application that is important to consider. Using point of care ultrasound for patients with respiratory distress, just what I mentioned before, being able to identify the presence of pulmonary edema versus a COPD exacerbation is important. Identifying patients with free fluid, patients who are non-trauma, so basically ectopic pregnancy patients who present with free fluid was important for us. And then using point of care ultrasound for cardiac arrest is also something that we're incorporating. So I'm happy to discuss any of these in detail. Yeah, just let me know which you want me to focus on.
I believe that it plays an important role in cardiac arrest, especially in those patients with undifferentiated shock. What do you think?
Yeah, I actually, well, this was actually what gave us street cred in our system. I think that by showing our EMS colleagues a handheld portable device that can basically switch a patient from a non-shockable to a shockable algorithm was a game changer, was huge for our EMS providers and provided us with, street cred to actually introduce this new device. And so whenever we talk about POCUS and resuscitation, I think it's important to mention the Reason trial, which was published in 2016, Gaspari et al. And so this was a multi-center observational study that was performed in 20 different hospitals in both the US and Canada. And their patient population was patients who had a non-traumatic out of hospital or ED cardiac arrest that presented with PEA or with a systole. And what they did is that they performed bedside cardiac ultrasound at the beginning and at the end of ACLS. And I think that from the EMS perspective, the takeaway points of this study were that the presence of cardiac activity on POCUS leads to greater likelihood of survival, both ROSC as well as survival to discharge when compared with patients in whom there was no cardiac activity in the initial POCUS examination. 2, POCUS also can help us identify reversible causes of PEA arrest. And so in these patients who presented with pericardial effusions or with signs of right ventricular strain in whom interventions were performed, their survival was also higher. And then finally, it does justify resource allocation, again, specifically in places such as TJ, where we don't have as many resources as other places. Being able to use point of care ultrasound as an adjunct for termination of resuscitation was important. So in addition to the Reason trial, I just want to mention the CASA protocol that was published in 2018, where it's a very nice stepwise approach, incorporating POCUS to ACLS. And we've used the CASA, but modified it for the pre-hospital. And so just to So for our listeners, the CASA protocol is a stepwise approach where you ask basically 3 questions. And the 3 questions are is there cardiac tamponade, yes or no? Is there right heart strain, yes or no? And is there cardiac activity, in that order? What we're doing in our EMS agency is basically doing this modified pre-hospital CASA protocol, not published, not validated, just empiric. But where we basically ask the first question to be, is there fine defib in whenever you're looking at the heart? And if that is present, then we step away from the PEA asystole algorithm, and we go directly into shocking that patient. And the next question is there pneumothorax? Because again, there's an actionable something that you can do in pre-hospital. And so if there is a pneumothorax, then needle decompression. And then after this, we just go ahead and follow the CASA protocol. And that can help us with transport decisions, or it can help us finally with the termination of resuscitation. So kind of the conclusion would be that point of care ultrasound can be a very helpful in resuscitation in pre-hospital, at least in our experience.
And it can not only help you to identify those reverses causes, but also to confirm if indeed there's a cardiac standstill or a patient with a systole, right? And like we know that instead of doing prolonged futile resuscitation, it can help you guide into the process of making any other step for the care of the patient, or having that difficult decision of terminating resuscitative efforts versus transporting. Why? Because it gives real-time information, and it's actionable information. It's funny because I know that at Dr. Raczek's agency, we kind of also did like a little CASA protocol. So I love that you guys are also using it. Dr. Raczek, can you explain a little bit more? What other applications have you been incorporating into your practice?
Absolutely. So, I mean, I can't agree more with everything that's been said. Excuse me. Obviously, Dr. Tovar has the ultrasound training, so it's probably at a more advanced level, where we just started out in my agency, as you know, Dr. Marrero, since you got the opportunity to help us out with implementing this program within the last year. Really, the main focus was lung, as we had mentioned, primarily because we also introduced high-dose nitroglycerin for the pulmonary edema patient. Excuse me. And so that is, as we all know, plenty of patients present with undifferentiated dyspnea. Many have underlying COPD and or CHF. So absolutely game changer when it comes to kind of your treatment algorithm, once you can look for those B lines, et cetera. And then secondly, the big application has been for cardiac arrest. And so I think one of the challenges has always been, well, let me just backtrack. Patients in cardiac arrest in the pre-hospital setting, right? What the heck do we do with them? So there are some systems that transport every patient in cardiac arrest. My personal and professional opinion is that that is not the right thing to do. That being said, you have to empower your EMS crews and agencies, and paramedics and firefighters to know when pre-hospital termination of resuscitation is appropriate. And obviously there's not necessarily one answer for this, right? We all talk about pulse checks and the basics, which we know, but it's been proven, in studies that manual pulse checks are really not very accurate. So now take that patient in the ED setting where you're trying to check a pulse during a chaotic code and apply that to the pre-hospital, right? Now you're in somebody's bathroom on the side of the road, etc. So that just stress of that whole situation just becomes extrapolated. So the ultrasound is an additional tool to really help either confirm cardiac standstill and medically do the right thing for the patient. Like if we know the effort, any further effort would be futile, then why continue, right? And that's to not give the patient, their family false hope, to not put the medics in danger for having to transport someone who has no chance of survival, which we know those additional transports, especially if you're including lights and siren, can be dangerous for the personnel. And really just looking at a larger resource picture too, bringing that that patient into the hospital. What do we do as ER physicians? Generally, first thing we do, recap what happened, pull out our ultrasound, confirm cardiac standstill, and terminate the code. Then we have all the additional implications of now that individual is in a room that can't be used for another patient. You know, the family arrives several minutes later and is probably confused as to what occurred. So, you know, there are circumstances in which that may be appropriate, maybe considering certain, you know, pediatric or certain types of patient pre-hospital arrests that might benefit, you know, from a transfer to the hospital for different types of resources available there. But medically speaking, strictly, you know, from a pathophysiology standpoint, if our crews have completed a proper ACLS protocol, gone through H's and T's, what else is there to do, right? So the only thing that really came to my mind is introduce the ultrasound. And again, just like you all had mentioned, looking at pseudo PEAs and seeing if there's anything that can be reversed in that seemingly PEA arrest, which actually isn't, is simply a low flow state, right? And there's a lot of tools our guys and gals out there can use, or if it's an asystole patient or a true PEA, then confirming that that cardiac standstill and being able to comfortably and kind of very succinctly be able to terminate that code pre-hospital. Some other things I've been thinking about were mentioned a little bit previously, you know, with obstetrics. It's not something we're doing yet, but certainly I can see a huge benefit to maybe an undifferentiated syncope patient who's a female of childbearing age, doing that fast exam looking for free fluid and suspecting ruptured ectopic. Another tool many agencies have now in the pre-hospital setting is whole blood. So really changing the game here, right, with this pretty simple tool, and, you know, going on further to possibly vascular access, confirming endotracheal tube placement, et cetera. So some future directions I'm kind of thinking about.
And probably some regional anesthesia as well in the future with all those traumatic patients, dislocations, fractures. We've talked about the use of the ultrasound in thoracic, but both of you, I know that you perform ground transport. I think that most of the air transport agencies can also benefit from this, right? Because prior for them to fly, they can like scan over the patient and see if there's any other pathologies or any other scenarios that can complicate that long transport, particularly if they have any pneumothorax, right, where they need to do any type of decompression or other procedures. What do you guys think?
Yeah, absolutely. Absolutely. I mean, and then just adding on to the list that Dr. Raczek just kind of mentioned regarding the POCUS applicabilities, I think that it's important for every agency to actually go ahead and, if you do QA of your images and you review the images, I think that it also helps you decide what other applications your agency will require. So at least in our experience, we've been doing QA monthly. And it's interesting because when I'm reviewing the EFAST studies, one of the things that I saw was that there's a lot of our patients actually had signs of small bowel obstruction. And so at least in our agency, one of the things that we're going to do is we're going to start teaching them how to identify small bowel obstruction with point of care ultrasound, given the amount of small bowel obstructions that we're seeing in our QA review. And then I do want to emphasize that at least in places where it might be, I don't know if Puerto Rico has the same issue, but in Tijuana, we don't have capnography and we don't have end-tidal CO2 in our ambulances. And we do have to intubate a lot because supraglottic devices are more expensive. And so ET tubes are cheaper and more available. So the use of ET tube confirmation with ultrasound is huge. And it's a fairly easy skill to teach. So again, I think that just depending on your resources and your location, you can decide what type of POCUS applications are needed. And so kind of just to emphasize your point, Dr. Marrero, using POCUS before flight is absolutely something that can be very beneficial for our colleagues.
Awesome. So I'm glad that I'm having this conversation with two successful women that have implemented the POCUS training on their agencies. Let's shift gear and talk about some of the challenges that both of you have faced. Dr. Raczek, can you address some of the barriers you faced for your implementation? How did you even sort out the initial conversation with leadership positions for your agency?
Sure. Yeah, that's a great question. I'll start off by saying that it is a process. And I think to be done properly, it should be a process. I will say, with no offense to my other EMS colleagues, but sometimes, and we're all guilty of this, right? We get a new tool, a new toy, quote unquote, and we really jump on the occasion and the opportunity to use that. And especially in the state of Texas, which has delegated practice for EMS, the medical directors can really do whatever we want, which is a blessing, but can be a curse. So you got to do things right. And that's, just my opinion. But so of course, when I became the medical director for my agency back in 2020, we had sat down with the leadership of things we want to address, change, improve, et cetera. And ultrasound, POCUS, is one of the first things that came up. So luckily, my agency is very supportive, and they were supportive from the beginning. That being said, there are always challenges. First of all, who do we train? The agency is moderate size. We have about 150 personnel, most of which are paramedics, just a handful of whom are at the EMT level. But, so who do we train, right? Secondly, how is that training going to take place? So the initial training, what do you do? An in-person course, online course, a combo? We ended up doing a combo. Then we did a several month sort of hands-on opportunities for hands-on training. And I would come in, and other EMS fellows and physicians, such as yourself, would come in and help the medics out and do kind of real-time training with that, that was all followed by a written exam, and then a credentialing with myself or another EMS physician or fellow prior to actually releasing these medics with that skill. Another challenge, of course, cost, right? And tied in with that is, which one do we get? So we approached that by requesting several different handheld companies to come out and demo their product. They were actually able to leave it with us. I believe we chose 3 that we kind of played with and explored the different capabilities, looked at the cost, and of course, part of that also the cloud, if there's a cloud storage, to be able to do that QA/QI. Which was, turns out in our case, a separate cost. So that was a challenge because we purchased the equipment once we decided who is going to train on it, who's going to have it, how we're going to train. And then it's like, we need to now pay extra to have that storage to be able to review those images for educational purposes, right? And so the challenge with that became to have to reapproach our board of commissioners, like a city council, to ask for more money basically for that, and to sort of sell why that's important, why that's necessary from a physician perspective, and training and continuing education perspective. So luckily that went very well, but I did have to, go in front of the board and pretty much ask them for those additional funds. And then the last piece, is adjusting and changing the protocols and incorporating that new skill set that only applies to some of the paramedic levels. We ended up going with, we call them provider levels. And so we went from a PL4 to a PL5, and the PL5 is the one who does the ultrasound. So to be able to incorporate that new level of paramedic effectively into the protocol, and how that ties into the big picture. So then, of course, the other challenge is technology. So initially we had rolled out the handheld devices. They were working great, but there was actually an issue of them coming across through the cloud. So that was discovered, a few months in, and there was a lot of like auto updates that occurred in the middle of everything. So we had actually talked to the manufacturers about, hey, can these updates either be manually done or done first thing in the morning, because it would be noon, medic would be out with a patient, and the thing would just auto update. So lots of things beyond our control, but that still affected us. That you just have to think about always with technology, right? So those are some of the steps we took to truly implement this program and some of the barriers we faced so far.
Did you had any hesitancy in terms of that implementing this type of system will increase a delay, will provoke a delay in transport?
That's a great question. And that's certainly something you have to think about with really anything that's introduced to pre-hospital patient care, right? And mitigating that, really the thought process of stay and play versus load and go, right? And what is that sweet spot of doing the right interventions at the initial patient contact versus in the back of the ambulance versus while transporting versus not, right? And so there's kind of a spectrum there. So, I think that in my particular agency, we have a long enough transport where it doesn't delay transport. That being said, that's changing. In my particular area, we now have multiple hospital systems. So our transport times have been shorter. So I'm curious to see how that will affect things. I think that really comes down to looking back at your times, at your data. And I know there's been studies done on this. And so looking to see, the study, I believe, concluded that the transport time may be delayed by 0 to 6 minutes. So, I mean, that's, a range there. At the end of the day, does that really matter if it's allowing you to perform better patient care? I don't know the right answer, but I think that's something to consider and think about. And, I certainly think that there are many agencies out there that are either, suburban to rural or, of course, air transport EMS agencies that certainly would benefit, and that few minutes of time that an ultrasound can be done, I think really, albeit it might delay the transport, I think it adds to the patient care at the end, and that benefit outweighs that negative, if you will.
We are emergency medicine physicians, and we know, right, that it can be a game changer of applying it in the hospital as well as in the field, right? But I'm stepping into the shoes or the mindset, right, of a medical director that was not trained on using ultrasound on his time of training, and can even question if it's right or wrong, probably wrong, to implement this type of system because of the lack of data, right? There was a survey back in 2014. I believe that it was like McLaughlin Taylor that did it. And he sent a survey to EMS directors and showed, right, that most medical directors wanted evidence that pre-hospital ultrasound improves patient outcomes before implementation. What could you say about this, or what's your posture about it?
So I think that, again, going back to what I had said earlier, several of my colleagues would probably, I think everybody would agree. The caution I would give is to implement something that's new, that's considered the exciting new toy without that evidence. That being said, the pre-hospital setting is still, advanced care in the pre-hospital setting is still very young, for lack of a better term. And there has to be a trial and error period to gather that data to properly make the final conclusions. So I think that, as long as there's no harm and your agency can get the ultrasounds, and there has been a lot of literature proving benefit, including in the pre-hospital setting, then I would say, why not? Of course, the argument back would be costs and all the other things we mentioned before, which are 100% valid. But I think that, this also, even if you're not implementing it as a medical director for your medics, but you yourself as a physician in the field, which there's a lot of emphasis of trying to get actually docs out in the field, EMS physicians out in the field, it's a tool for them to use as well. And again, it doesn't have to be implemented in 5 minutes to every single paramedic in your agency. If there's a proper process of selecting the right individual to do it on the right patient, and then gathering that data and looking back at it and looking to see how that affected patient outcomes, I think most medical directors would be convinced to at least give it a shot if they feasibly can.
Dr. Tovar, you, on the other hand, were able to work in the rural, more austere environment with probably a lack of more resources, equipment, and funding. How were you able to gain the support of your Cruz Roja Tijuana's medical director in upper levels?
So just to clarify, Tijuana is actually urban. It's quite
sorry.
urban. No, it's fine. But our transport times are quite, we can go from 15 minutes to 120 minutes. So our transport times are quite delayed. And so I think that a point that Dr. Raczek was mentioning, I think that places where your transport times are very short, POCUS may not be the best thing to implement versus places like ours where our transport time is longer. So kind of answering the question, our main challenge was with resources, with basically equipment and middleware because of the cost. And it's very hard to decide that you want to do point of care ultrasound when you're in a system that in which you have to decide, am I going to get X tourniquets or not, because we don't have enough money. So initially, I had decided that POCUS was not an option for our system because of the resources the financial burden that it would lead to. However, we were lucky enough that we got a donation, a very generous donation. So we had 15 butterflies. Can I mention butterflies? We had 15 handheld ultrasounds that were donated with an iPad. And so once we had that, then that led to now starting to actually do the education and the training, given that we already had the equipment. And the challenges of education or training have already kind of been mentioned before. But the first thing was just building a curriculum, which I've already kind of alluded to, but based on whatever numbers we had and what we were seeing, we decided what POCUS applications were the most high yield in our own system. And then with regards to the training, we first had to figure out who we were going to provide the handheld to. And we decided that it would be paramedics. And in Mexico, in addition, we've got intermediate EMT. So basically, we did not provide, or we did not give the machine to basic EMTs, but it was mainly to intermediate and paramedics, just because there has to be an understanding of basic anatomy for kind of appropriate usage when training, at least in the initial stages. So with regards to how did we teach them, it was similar to what Dr. Raczek did before. So it was, we had an asynchronous component of it, which is challenging because there's very little FOMED material in Spanish. So we had to build, the
curriculum in
Spanish. And the free open, like we basically have a web-based platform that is free open access in Spanish on point of care ultrasound, Gadupando Latinoamérica, shameless plug. And in that platform, we also there's we discuss EFAST, we discuss the RUSH protocol, etc. So that was just provided to our EMTs and paramedics. We also added hands-on, of course. So it was, I would say what we did was at least providing 2 to 4 hours of hands-on for each application. And then it was really important also to incorporate simulation-based hands-on to a training. And then once we did that, we also had to make sure that there was that we were following kind of like the trajectory of each paramedic and EMT. And so that's where we added the QA reviews monthly to look at their diagnostic accuracy, provide feedback, etc. And that's currently where we are.
I like that you mentioned who were you training, because that was going to be one of my questions. Who are we supposed to train? But I think that both of you agree that definitely the higher person in training, because of the complex of understanding anatomy and how basically the body works, right? But do you think that eventually anyone that gets into the truck should be trained, or to at least work as a second hand for that initial, I was gonna say provider, for that initial
Sorry.
paramedic?
I think it depends. If you have a limited number of machines or handhelds, then I think that the people who are gonna be able to both do the image acquisition as well as the image interpretation at the same time should have a handheld, and that those would be the like paramedics or EMS physicians. Um, so at least for now, I would stick honestly with paramedics and EMS physicians at this point. If we are in a system where everyone can have a handheld, and I'm thinking about it out loud. I think that if I mean, at the end of the day, in the back, like in the rig, there's also like a finite number of personnel providing care. And so it's not like the ED department where you have the medical student who you can teach because there's space for 20 other individuals in that same room. In the back of the rig or on the street or in that bathroom that Dr. Raczek was talking about, there's a limited number of people. And so I think that the health professionals who are actually using the handheld should be the ones who can do acquisition and interpretation at the same time.
Perfect. So now, at least you're ultrasound trained, right? And Dr. Raczek, she is EMS trained, not ultrasound, but at least she is an institutional facility where she can at least have help from her ultrasound department. What about that medical director that wants to get a type of training in the ultrasound field? What would you recommend or advise for them as a starting point of learning? Would it be like a half-day ultrasound course, a whole day course, hands-on only? What type of learning?
I would think it would be a combination of all these. So basically, like a synchronous learning, hands-on learning. I would suggest that it wouldn't be a specific number of like. I would suggest longitudinal learning. That's what I'm trying to say. So as long as you have constant both acquisition and interpretation and clinical integration of your imaging, that is what I would recommend. If you look at ASEP, it's the 16 hours of theory plus some hands-on training. I think that at least in the EMS world, given that it's mostly protocol driven, it would be I would recommend that you would have kind of ongoing CME or ongoing training on point of care ultrasound instead of just a hard set number. Does that make sense?
Yeah, I think that we can all agree that it will need to be a longitudinal, ongoing type of training. The more you practice, the better you become at that particular skill. And well, times can change and you want to adapt to our current time. And if you were trained back in the day where you didn't get this type of training, well, you need to evolve, right? And be able to embrace the changes and be able to learn. So in terms of credentialing, I think that I'm a little bit biased because I'm in both of the fields, but I try to put myself in the shoes of the ultrasound trained versus the EMS trained person. And well, it's not only it's difficult to start this process of implementing the POCUS, but right now we implemented the POCUS. So how do we credential our medics? What's the perfect number for them to be called proficient? Because you know that for the ASIP, right, trainees should complete like a benchmark of 25 to 50 quality review exams in X or Y particular application. For our residents, we know that they need to get a benchmark as well, but they have like a 3 or a 4 year long time frame, right? Depending on the program to complete these studies. Ultrasound fellows that are in training, they have a year long to do it. What about for our medics, right? What's that number? If we can establish a number so that they can become proficient, or we can credential them, and yes, you're going to be able to do it on your own, and I have no doubts on you. What do you think?
Well, the way how we've done it in TJ is they have to have, for each application, they have to have at least 10 studies in a healthy model of that application, and then 15 studies in like with patients. So our number is 25, kind of following the ACIP guidelines. And then during our QAs, we review the diagnostic accuracy, and feedback is provided if we see some egregious usage of point of care ultrasound. Then that specific paramedic or EMT will be provided with feedback about how to improve that application in particular. So for us, the number is 25 per application in both healthy patients as well as healthy models, or as well as patients.
Dr. Raczek, do you think that this could be like a fair number to type of generalize it for other agencies?
Yeah, so I agree. I will also add that I was lucky to, as you mentioned, I'm in a department here that also has an ultrasound division that's very active and engaged. And so we had initially spoken to some leadership within their group, specifically asking this question. And one of the perspectives that I got was, demonstration to competency. So not necessarily focusing on the number. And I kind of was a little bit hesitant about that, because I think, as physicians, everything we do is so checklist number focused, right? Do this to get to med school, do this to get to residency, so on and so forth. So I was a little bit hesitant, but one thing, and I don't know if Dr. Tovar had a similar experience, or you, Dr. Marrero, but I did notice that there were some medics, just like any other trainee, I think, or medical professional, who really got it right away, and others that just really didn't. And then there's some that was in the middle. And I was honestly very surprised. And I'm not so much talking about like the interpretation, but just even the use and acquisition of the image. Some just really understand the concept of ultrasonography. And so I think setting an, quote unquote, artificial number, I don't think is the right approach. That being said, I do agree there should be a bare minimum to demonstrate, to just practice, if nothing else, even if they demonstrate competency on the first time, we all know that's not enough, right? And we have to just continue acquiring images to continue getting better at them, even if you start off a little bit at a higher level than some of your colleagues maybe. But I do agree. I do really actually like the approach of doing several on healthy models and then others on patients, as we know, which can have very different anatomy and body habitus, et cetera. So I really like that model, but I do strongly also believe in demonstrating capacity without necessarily a strict number. I think once we start to get to the really high numbers like that are expected of physicians, and I mean, you guys know, ultrasonography, emergency ultrasonography is a whole separate fellowship for a reason, and because you're experts in that, and we cannot expect the average paramedic, even the advanced paramedic, to be an expert in ultrasonography, just like not all EM physicians are. So to that point, I'll say also, like for myself, I certainly don't claim to be an expert in ultrasonography. I can just really do the basics of regular ER docs, right? However, we all go through that training residency, but to prepare for this, I did take an additional course, which is similar to what we're discussing here, as the physician, to kind of also prove that I'm proactive, continuing my own personal education. And it was a course offered through another EMS organization that was like a part of a pre-conference, very well put together with ultrasound and EM and EMS physicians discussing their experiences and going through different applications and pretty much what we're discussing today. So that was very helpful. And I will say personally, every time we train our medics, I try to get in there as well and get my hands on the probe and also, test myself and keep practicing myself.
Yeah, the better, the more numbers you scan, the better you become at it. But as well, the more normal type of patients you scan on, then it's easier for them to identify any type of pathologic process happening, right? But we standardize those patients that they're supposed to scan, or those numbers will be counted by scanning on themselves? Is it clear, the question? No? Okay. Like in terms of if we're gonna standardize the number for the credentialing, we're counting pathological patients, real life patients, or are we also counting practical patients that standardized type of practical patients that they need to be scanning during their off time?
I think that if we look at what we do with the EM physicians, we can kind of extrapolate that. And so ideally you would want them to have like at least 5 to 10% of the scans that they do for these to be pathologic, right? So and in some cases, for example, if you're looking for free fluid, you can always go ahead and go to a dialysis unit and like scan abdomens there, and you're going to see free fluid. But in other cases, it's just difficult to simulate. So I do think that in addition to like the asynchronous learning, the hands-on, the simulation-based, one other strategy of teaching, which does require a little more effort from the EMS medical director, whoever is driving the ultrasound program, would be to actually do some ambulance rides with the paramedics and EMTs and scan with them, if that's possible. So kind of answering your question, I do think that having experience with pathology, with real-time pathology is important to not only for acquisition and for interpretation, but also for clinical integration.
Okay, and in terms for the quality assurance and quality improvement, how did you establish that process in your agency? How are you doing it?
I think that the one important thing that we were focused on whenever looking for handhelds was that middleware that Dr. Raczek was kind of alluding to before, and at least in our choice of handhelds, Butterfly has their own middleware, and so what we do, and it makes it easier because we can just do a zoom in. And what we do is we look at we can share all of the different folders that our EMTs and paramedics have, and then just go through their monthly studies. And that can be done, through Zoom. So that just makes it easier. And that's what we're doing. It's a 1 month Zoom call, lasts an hour, and whoever is on working that day can log in, and we just go through the studies.
How many studies are you guys doing in a day that you select to do QA/QI?
It depends, but it's usually between 15 studies in like during that time. And we choose the studies based on, like, what I'll do is I'll log into the cloud. I'll take a look at the studies that they did during that month. I'll choose the ones that I think have the most educational potential, and the studies where there was a mistake with diagnosis, right? So, and based on those, then we'll just review the images with whoever is logged into the Zoom call.
On their report of the patient, they're also integrating the findings of the ultrasound?
That's a great question, and I need to remind them all the time. Yeah, so the middleware that we use is in English. There is no Spanish middleware yet. Hopefully that will change eventually. Plug in for whoever is designing these middleware packages or whatever. But yeah, so like I need to remind our paramedics and EMTs that they have to add their sonographic interpretation to their images. And so what I ask them is to literally type the indication or the presentation of the patient, the indication for the POCUS exam, the their sonographic interpretation, and then the disposition of that person. So was that the EMS is different in Mexico, but was that patient stayed at home? Was the patient taken to the hospital? And what type of pre-hospital intervention was done during that 911 call?
And I'm thinking one step further. Are you guys also billing for these?
No.
No.
The pre-hospital care that we provide in TJ is free, absolutely free for the user. So yeah, so we don't bill.
Do you think, Dr. Raczek, that eventually, I know the conversation is establishing it or not, but since we're talking about it, do you see that near the future, there could be a possibility for that agency to start billing for this type of procedure, since they can also have kind of a hesitancy once we present them, okay, I want to start the POCUS on my agency. I know that the equipment, machinery, middleware, it's pretty expensive, but also if we do it the correct way, we can also bill for it. And it's a win-win for both parts. What do you think?
That's a great question. I mean, I think there's a potential, but just like anything in EMS, we have to be very careful. Just like with anything else we do, oftentimes patients in the pre-hospital setting are very fearful of EMS interventions and transports. They think they're going to get a big bill, so they might be limiting their ability to get care with the financial fears. Additionally, I think that can open up some questions about medical legal issues. This had come up in my experience with, well, what if something is missed on the ultrasound, right? And I think that goes back to what we had discussed before about, if you're teaching an EMS clinician to perform an ultrasound, we're really doing it to rule out certain diagnoses, right? Like pulmonary edema, pneumothorax, et cetera. Not so much comprehensive lung exam, for example, looking for, maybe small lung nodules. That's not something we would be trained to do. But, when it comes to billing and the potential for missing things, I think that does open up some medical legal questions that would really have to be discussed prior to anything like that occurring. But as of now, I don't anticipate any billing occurring for those services.
I think that at the beginning, it's a new toy, like you said, Dr. Raczek, and it's like hot out of the oven. Everybody wants to do POCUS, right? So everybody is engaging. Everybody wants to learn. What happens when you're 1 year on it, 2 years on it? Like, what are ways of implementing constant educational that it's real, it's done correctly? I don't know if this is like talking more unnecessary things. I don't know if you guys want to.
No, I think that's a great question. I'll just very briefly comment on that because that's kind of the stage we're in. And I'm actually glad you brought that up. And it's like with anything else where you can lose that momentum, right? I think is really where you're getting at. And I have personally found that a challenge. So just a simple example, we have a group me with the level of medics that are providing that are doing ultrasounds, and it kind of falls on the medical director and all of us really to continue like showing images that were acquired in the hospital or in whatever other setting, or some interesting article off the internet, a new study, things of that nature, to really keep them engaged. Because what I noticed is the first few that were taught to do this skill were the ones that really wanted to do this skill. They are the ones who love EMS, love paramedicine, were very excited, have been waiting to do ultrasound for a long time. But as we expand our program, at least in my agency, the medics that are learning it now are also excellent, but maybe they're newer, less experienced. For us, with this provider level 4 to 5 increase, there is a financial change as a salary change as well. So, how do I keep that excitement going? It's an excellent question, and I don't know the right answer. So far, all I've been able to do is share my own images or images of colleagues from the ED, along with like a little case study. You yourself, Dr. Marrero, provided one last year, which they loved, showing a lung point in a pneumothorax, and they thought that was just so cool. And just trying to stay engaged, I think, showing up to the hands-on sessions, the continuing education. Just, seeing the doc there, I think is helpful too, to keep that excitement and momentum going. If new studies come out, sharing those, and again, I don't know. And if you know the answer, please tell me because I'm still trying to figure it out. We are just in our first year of doing this, so still lots of learning ahead for sure.
What about you, Dr. Tovar?
Well, I guess engagement is important. I guess one of the things that we do is we have monthly workshops. We don't only do the QA, the virtual Zoom with the QA, but we also do monthly workshops where it's not only EMS providers that come to the workshops, but also residents that are IM and EM from TJ and Mexicali, which are kind of cities that are close by. But then the other thing that we have to do, just because of the resource, because of the limited number of machines that we have, is there's a benchmark. And so I basically look at the numbers that each individual has performed in the last 6 months. And if they have less than, and it's an arbitrary number, there's no literature supporting this, but if they have less than 5 to 10 per month, then I thank that person for their involvement, and then I look for other people, for other EMTs and paramedics who may be interested on learning, and we start all over. So I agree.
Keep it up. Keep it up.
Yeah, hopefully if there is a more efficient way of keeping the engagement, I agree. I mean, it would be great to hear other stories about that, because it's hard.
Well, I think that that's a topic for future conversations, because everybody is kind of in the honeymoon phase right now.
Yeah.
Right?
Yeah.
So can you guys provide any real life case application to inspire our listeners besides the ones that you already shared? Dr. Raczek, if you want to start with your example.
Sure. The first one that comes to mind, really, the best one I have is already touched on this a little bit before. Patient with pulmonary edema, I believe from CHF, uncontrolled CHF. Again, now we have the high dose nitroglycerin. So prior to that, we were trying sublingual nitros, thinking about BiPAP or CPAP, right? It was a process. And now with this particular patient, medic was able to see this patient with shortness of breath, dyspnea, increased work of breathing, apply the ultrasound, see lots of B-lines everywhere, realize the patient has a history of heart failure, and very quickly implement that large bolus dose nitro, and really significantly improve them before they even got to the hospital. As we know, this kind of intervention, prevents lengthy admissions, intubation. So this is really spectacular, just with 2 quite simple, non-invasive interventions. We were able to save the patient, from arriving to the hospital now critically ill and worsening pulmonary edema, respiratory distress, possibly needing intubation. So that was a big win for us.
What about yourself, Dr. Tovar?
From us, there's 2 that come to mind. The first one was a 21-year-old gunshot. He had multiple gunshots to both upper extremities and the right side of his chest. And so in that case, one of our stellar EMS paramedics, what he did was he did an EFAST, initially identified a pneumothorax, decompressed the patient in the field. Patient was still hypotensive, so he went down, did the abdominal portion of it, and then noticed free fluid. And I think the important part of this was that in certain emergency departments in Mexico, there is no point of care ultrasound. So we only, the ambulance has POCUS, but the ED doesn't. And so he let the ED personnel know in that hospital, and the patient was kind of swiftly taken to the OR. And I think that was a big win for many reasons. One, the patient actually did survive, which is always very very good to hear. But also, I think that it just emphasized how it takes a while for the ED people to actually recognize that EMS providers can actually, perform perform point of care ultrasound. And so it just empowered our paramedics because they were letting the doc know what the next steps were. So that was a good example for us. And then the second one was also a patient who came in, vaginal bleeding, free fluid in the belly. The EMS provider took her to a hospital that was focused on OB care. And it was the ED providers didn't believe our EMS person, but then she showed them the images, and they couldn't really decline the admission or decline the patient. So those two were a good win because it just showed how by training our EMS providers, we can actually change the outcomes of our patients. So
I know that most agencies can have their trauma protocol already established, right? But when you have a traumatic patient that it's not responding, grab that POCUS and look for something else that you're missing, right? That's gonna definitely change your care for that patient. And well, we know that POCUS is transforming the way that EMS providers can do an assessment, right? Can diagnose. You guys exemplify that the management of the patients in the field can change, right? And its importance lies in its ability to enhance that decision making, to optimize resource utilization, like you guys said, and improve that patient outcome in time-sensitive scenarios. So thanks, both of you, for being here, for taking the time to have this awesome discussion. I think that this opens a forum for more to come, right? And thanks for being here. We encourage our listeners to advocate, right, for POCUS integration in their EMS system if they're part of one. And I will also will like to take the time to give a special shout out and as an appreciation form for Dr. Ryan Newberry for his collaboration, even though he was unable to be here with us today, as well as Dr. Melissa Mayers for the opportunity of this sectional collaboration. So thanks again for hearing us, and I hope you guys enjoy our discussion.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.